Hello, my name is Eduardo Hernandez, and I will speak to you about the role of coronary calcification in risk stratification. The evolution of the atheroma and calcification is a lifelong process. It begins by the local retention of apolipoprotein B in the subintimal space. This leads to a recruitment of monocytes which enter the subintimal space, and phagocytosis of the lipoproteins occurs, promoting the immune response and with the formation subsequently of an atheroma. Over time, there is transdifferentiation of chondrocyte or osteoblast-like cells, which leads to deposition of calcium, initially microcalcifications coalesce into areas of macrocalcification or spotty calcification. This time of the development of atheroma is a particularly risky time where there's more risk for plaque rupture and acute coronary syndromes. Subsequently, the atheroma matures and there's dense calcification with improved plaque stability. However, the presence of calcification, as we can detect on CT coronary calcium scores, implies that there are other areas of the vasculature that are in a state of active atheroma development and are the nidus for potential instability. There are several risk factors for calcification: advanced age, type 1 and type 2 diabetes, and CKD, with millions of Americans suffering from these conditions and very large populations that are growing in those over 80 and in the presence of diabetes in our U.S. population. If we look at the presence of calcifications in the MESA study, a study which looked at risk factors in a multi-ethnic population of patients, what we see is that about half of the population had coronary calcification on their first exam. And if we look at the diabetics specifically in the population, the presence of calcification was over 60% in those patients, and in patients with chronic kidney disease, it approached 70%. There's an additive effect of risk factors on cardiovascular disease events. And this is data from the Framingham study, where over 7,000 patients were assessed. What you see is in patients with a single risk factor, such as elevated cholesterol, the 5-year event rate is relatively low per 100 persons. If you continue to add risk factors, such as having a hypercholesterolemic smoker who has a low HDL, is a male diabetic with a markedly elevated blood pressure over the age of 60, their risk of having an event is close to 40% at five years. The appreciation of the cumulative effect of risk factors has led to the development of formulas which we've been using for the past 2 decades. Currently, we use the ASCVD pooled cohort equations to determine 10-year risk in our patients and to look for indications for risk-reducing therapies such as lipid therapy and antihypertensive therapy. The MESA study, mentioned previously, looked at several populations of patients in the U.S., and it included non-Hispanic whites, Chinese Americans, African Americans, and Hispanics. It incorporated traditional risk factors and family history of myocardial infarction, as well as the use of coronary artery calcium scores to help ascertain the long-term risk of these patients. The MESA study showed us that there was a graded increased risk of cardiovascular events according to the person's calcium score. If for a calcium score of 0, the 5-year risk of having a cardiovascular event was negligible. At 5 years, if your calcium score was above 300, you had about a 5% risk of having an event. This has been supported in numerous other cohort studies that have showed the effect of coronary calcification on cardiovascular risk. This study, again, looked at patients from MESA and assessed the impact of having risk factors in addition to having elevated coronary calcium scores. What you see is for a patient with a calcium score of 0 in yellow, the addition of risk factors increases risk, but the event rate per 1,000 person years was only 3 if your calcium score was 0 and you had 3 or more risk factors. A patient with a calcium score of over 100 with no risk factors had a higher risk of events than the patient with a calcium score of 0 and multiple risk factors. And as is obvious in patients with calcium scores of over 100 and multiple risk factors, the addition of risk factors in the presence of coronary calcium has a significant additive effect. This has been recognized and adopted by numerous clinical practice guidelines throughout the world. And what we can see that the use of coronary calcium score is consistent for certain indications. Patients who are asymptomatic, who are over the age of 40, and have an intermediate risk, coronary calcium score has an additive effect that's helpful in determining the benefit of risk-reducing therapies. There's common treatment thresholds that most guidelines have adopted. For a calcium score of 0, the risk is downgraded, and you can consider withholding statin therapy for most patients. If the calcium score is over 100, you should consider initiating statin therapy and maintaining it. Where there's non-agreement is whether to use coronary artery calcium score for the use of aspirin and to determine intensity or adoption of antihypertensive therapy for patients with high blood pressure. The National Lipid Association produced a guideline that's very practical to use, and I'll focus on this because I think it's comprehensive and very helpful to conceptualize how to treat patients. In their guideline, if you have a family history of premature atherosclerotic cardiovascular disease and you're below the age of 40 and your calcium score is 0, you can adopt lifestyle therapy and consider repeating the calcium score in 5 to 7 years when we know there may be a development of calcium at the time. If the calcium score is more than 0, then they should be considered for lipid-lowering therapy with statins. In diabetics between the ages of 40 and 70, if their calcium score is 0, then you can add moderate intensity statin, and as the calcium score goes above 1 or 1 or above, either moderate or high intensity statin therapy should be considered, and above 100, high intensity statin therapy, and the addition of aspirin is reasonable. For patients who have LDLs of above 190, in other words, patients that may have a genetic form of dyslipidemia, the addition of a statin without more intense treatment if their calcium score is 0 is reasonable. For patients with calcium scores above 0, high intensity statin and additional LDL therapy may be considered. For elderly patients, those above 76 years of age, if they have a calcium score of 0 to 10, you could consider not giving statin therapy as they haven't developed disease even at this advanced age. For patients with a calcium score of over 100, then statin therapy should be instituted. For patients who have an LDL between 70 and 189 and who are between the ages of 40 and 75, if their 10-year risk is less than 5% and their calcium score is 0, they can continue lifestyle therapy and repeat calcium scores in 5 to 7 years. If their calcium score is over 0, lifestyle therapy and consideration for statin therapy should be given. For patients with calcium scores of 0 who are not diabetic, do not smoke, do not have a family history of premature vascular disease, you can defer statin therapy and repeat calcium scores in 3 to 5 years. In the MESA study, about 15% of patients who had calcium scores of 0 developed coronary calcification at that time point, and by 5 years, about a quarter of patients had developed coronary calcification. In patients who have a 10-year risk between 5 and 19%, a calcium score between 1 and 199 favors statin therapy in consideration of a repeat scan to intensify therapy if the calcium score is above 100. For patients between calcium scores of 100 and 199, it favors statin therapy and consideration for aspirin if their bleeding risk is low, and for intensification of their antihypertensive therapy. For patients with calcium scores above 300, it would favor high-intensity statin, and if needed, additional therapy to lower LDL, aspirin therapy, and targets of blood pressure of less than 120. There are exceptions for these intermediate risk group patients for down classifying. If you have a smoker, if you're diabetic, if your blood pressure is uncontrolled, if you have genetic forms of dyslipidemia, and individuals with prominent history of premature atherosclerotic cardiovascular disease, those are patients that you may want to consider adding statin therapy even if their calcium score is 0, because they represent high risk, high inflammatory states. The use of coronary artery calcium is implicated not only in the development of cardiovascular disease, but it is also associated with increased cancer risk. In this study, the Coronary Artery Calcium Consortium investigators looked at patients who were asymptomatic, who were between the ages of 40 and 75 and did not have known cardiovascular disease. They had over 59,000 patients. They were followed for about 10 years, and their median age was 55, 33% were female, and their AS-CVD scores were about 6.8%. They looked at sex-specific mortality rates calculated per 1,000 person years, and what they found was for women and men, the proportion of deaths attributable to cardiovascular disease increased with higher coronary artery calcium scores as expected, and the relative proportion of deaths attributable to cancer decreased. As you can see in the image, if your calcium score is 0 and you're a woman, you will predominantly die of cancer. 78% of deaths were from cancer and 21% from atherosclerotic cardiovascular disease. The same was seen in men. As the calcium score went above 400, both women had predominantly cardiovascular deaths. This slide shows the time at which cardiovascular death overcomes cancer death, or cancer death overcomes cardiovascular death for men and women. And what you see from the slide is that at calcium scores above 400 is when women's death rate from coronary artery disease increases above their cancer death rates. For men, this occurs at lower calcium scores of about 114. CT angiography has been incorporated now in our national guidelines for the assessment of patients with chest pain. And I mention it because of the important prognostic information that can be gathered by the addition of contrast angiography to coronary artery calcium testing. In this slide, we see how culprit lesions are different than stable lesions in patients who have CT coronary angiography. In A, you see a 3D reconstruction of a CT with a proximal right coronary stenosis. In B, you see a severe stenosis of the proximal and mid-right coronary arteries on traditional selective coronary angiography. And to the right, the same reconstructed image on the CT. And on the cross-sectional images, you can see contrast rim enhancement, which is a marker for increased risk in this patient who had an acute coronary syndrome. The spotty calcification that we mentioned in the first slide can also be detected by the addition of contrast to the CT images, and you can see that on the arrow on the right side of the slide pointing to those spotty calcification. In this study, they looked at over 100 patients that half of them had acute coronary syndromes and half of them had stable angina pectoris. What you can see is plaque volumes were higher in those with acute coronary syndromes. Remodeling index was higher. The density of plaque was lower, as was the minimal CT density in Hounsfield units. Spotty calcification was seen exclusively in patients with acute coronary syndromes, and contrast rim enhancement was also seen exclusively in patients with acute coronary syndromes. The additive prognostic value of adding contrast angiography was seen in this study that was published recently in the Annals of Internal Medicine. The study population was from the subclinical coronary atherosclerosis and risk for myocardial infarction in a Danish cohort study. They looked at over 9,000 asymptomatic persons aged 40 and older who were assessed with a coronary CTA. The results of the study were blinded such that the treating physicians nor the patients knew the results of the study. They divided the groups in those that had obstructive disease and those that didn't, and those that had extensive disease and those that didn't. Extensive meaning that were multiple areas in the coronary tree that had disease. What they found was that the highest risk group for myocardial infarction at 3.5 years, which was the primary endpoint, was in those that had extensive disease that was obstructive. The next group of risk was those that had non-extensive disease that was obstructive, and those that had non-obstructive disease had lower risk. When they added death and myocardial infarction, which was the secondary endpoint, the findings were compelling. Patients that had extensive disease, regardless of whether they were obstructive or non-obstructive, had a higher risk of death and myocardial infarction. The risk was lower for those patients that had obstructive or non-obstructive, non-extensive disease. So the burden of disease was a very powerful prognosticator of events. If we look at the relative risk of MI with the addition of contrast angiography and finding patients that have obstructive extensive disease, it's significant, with a 12-fold increased risk of myocardial infarction compared to those patients that did not have significant disease. There are numerous ongoing clinical trials in Europe, the United States, and Australia. They are all assessing the value of coronary calcium score versus not testing patients to address lingering questions about the utility of the test. The Dankova study and the Robinska study are being carried out in Europe. The CoreCal study in the US, as well as the Accurate study. The Accurate study will be used to assess whether the addition of coronary calcium score, which can be performed during cardiac PET CT, will serve as a gatekeeper whether to progress with further imaging. The COT-CAD study in Australia will examine the value of coronary artery calcium score in patients with a family history of coronary artery disease. These studies will add to the immense body of evidence that supports the use of coronary artery calcium score in the risk assessment of our patients. Thank you very much for your time.